So what I have here in the red boxes suggests that the trial truly was a trial of immunotherapy patients minus plus radiation, meaning the patients all got, or 90% of the patients got immunotherapy, and then they either got radiation or did not get radiation, right, as per the protocol. And what is also in the red box below that is a suggestion that a majority of the patients had 2 or fewer metastatic sites when they were enrolled onto the clinical trial. So again, they had what we call limited metastatic or oligometastatic disease. And so, and just another caveat or point to make was that most of the patients had metastatic disease from their diagnosis through the point of enrollment after 4 courses of systemic therapy. There was a small percentage of patients, very small, who had too many metastatic sites of disease at diagnosis, but because they responded so well to their systemic therapy that there were just a few sites of disease remaining when we reevaluated them with imaging prior to enrollment on the study, and those patients were included on the study. When we looked at where we radiated, a majority of the areas we radiated in these patients were their primary cancer, where it originated, and 1 or 2 lymph node areas and 1 or 2 metastatic sites, okay? So after we did the initial analysis, we unfortunately got these findings. And the findings were that the progression-free survival was not much different in these patients that received radiation, unfortunately, meaning the addition of radiation did not statistically improve the patient outcomes in terms of progression-free survival, which was a little bit surprising because we saw such a profound improvement in those 3 smaller randomized studies that I described. But remember, those 3 smaller randomized studies were done prior to the era of immunotherapy. And it could have been that in this trial, the immunotherapy was doing so good for the patients, it kind of diluted the benefits that the radiation could offer with respect to controlling disease. But what you can see down here on the bottom, it says 1-year PFS rate. So 48% of the control arm was had a progression-free survival at 1 year versus 51.5% of the experimental radiation arm. And then the 2-year progression-free survival was 36% for the standard arm and 40% for the control arm. So there was definitely some improvement, but not statistically large enough for us to move forward with the study. And unfortunately, this was the curves of the overall survival as well. There was really no difference in the overall survival between the treatment arms, which was again surprising to us. 1-year overall survival for this advanced non-small cell lung cancer patient population was 76%, which is very good. 2-year overall survival rate was 56%, which is also very good. So, overall, the patients were doing really well on the study, but we didn't see an extra benefit from adding radiation. What we did notice were some trends, okay? These are not statistically significant, so we can't hang our hat on it. But one trend we saw was that the radiation, which we anticipated to help, probably did help. Looking at patterns of failure in terms of where the disease came back after the patients were treated on trial, there were fewer patients that had what we call an infield failure, which means that the radiation did its job and was reducing the recurrences that occurred in the original sites of disease that were actually radiated. So it did its job. It killed the cancers where it aimed. And so there were fewer what we call failures, but fewer recurrences in those areas. It also delayed, the radiation had a trend towards delaying the development of new lesions, meaning, so we give the patients radiation and wait to see if there's any recurrences, okay? It actually did delay the time that it took for patients to have recurrent disease. However, still not statistically significant, but just simply a trend in the right direction. But we do think that that trend in the right direction would have translated into a statistically significant benefit in progression-free survival and overall survival if we probably had done if we had tweaked the study a little bit or done something differently. And what do I mean by that? So when we looked at patients, what we found is that the patients who stayed on maintenance systemic therapy longer, which is the red curves here, statistically lived a lot longer and had a much greater freedom from recurrence, a time frame from freedom from recurrence than those patients that received much less maintenance systemic therapy in blue. And you're asking, why did certain patients get more maintenance systemic therapy than others? So there are three reasons why patients would have had to stop the trial protocol maintenance systemic therapy. One is if they died. Two, if they could no longer tolerate the therapy because of toxicity. Or three, if there was, some other reasons why they had personal reasons why they had to stop the systemic therapy. But what you can see here is the longer you stayed on those immunotherapy regimens, the better you did. But what we also found was that the patients that received radiation did have higher rates of lung toxicity. And because they had higher rates of lung toxicity, what we could show is that they had higher rates of lung toxicity. And because of that, they were not on the systemic immunotherapy for as long. And because of that, they had a worse progression-free survival. As you can see here again, the blue curve indicates the patients that did not have the toxicity. The red curve, which shows much lower progression-free survival, were the patients that did have the toxicity. And so what we've learned is that toxicity could have reduced the chances for us to translate the benefits of radiation to a survival advantage. And that's what you always have to think about. Every treatment is a balance of two forces: the benefits of the treatment versus the side effects or toxicity of the treatment that could limit the benefits. And it's a tug of war. And what we always want to do is optimize the benefits of the treatment and limit the toxicity. And in this case, we did not anticipate the toxicity, the lung toxicity, because of the combination of the immunotherapy and the radiation. But if we are able to do so in the future, account for that toxicity, predict which patients are at increased risk for that toxicity, we may be able to enrich and optimize the selection of the appropriate patients for these types of radiation local therapies, and by doing so, improve and in fact statistically improve the survival outcomes for our patient populations. And so I'll skip some of these slides just to get into some other simple concepts. Number one, if you had a better performance status, you were in better shape when you started the trial, you were going to live longer. So that's certainly consistent with historical literature. You're in better physical shape, you're going to live longer. Number two, the patients that had metastatic disease to the liver, even though we're offering radiation, those patients did worse. And so it may be in the future that we should not ideally include those patients when we use radiation in the management of metastatic disease to improve survival, okay? And so we're not done with this study. So just because we closed the study at an interim analysis because we were not meeting a statistically significant benefit doesn't mean that we've closed the books on understanding what we need to do in the future to optimize these treatments for the benefit of our patients. We still believe that radiation can be used in select patients to improve survival outcomes. We just need to do the work, including some of these translational efforts, to better understand which patients to select for the treatment. At the end of the day, that is the ultimate personalization of therapy.